Welcome to our Quality Improvement Project on the essential role of incentive spirometry in patient care. At DMC Huron Valley Sinai Hospital on Unit 2 West, a step-down ICU unit where there are patients who are often recovering from serious illness or surgery, many of whom are not yet mobile. Immobility puts these patients at an increased risk for respiratory complications such as atelectasis and pneumonia. Incentive spirometry is a simple breathing exercise that improves lung function. It helps prevent complications, enhances oxygenation, and can shorten hospital stays. It's used for patients with COPD, asthma, post-op recovery, respiratory infections, and anyone with limited mobility. Our Quality Improvement Project focused on the lack of incentive spirometry use on our inpatient unit. This unit treats post-surgical and respiratory patients, among others, and through our overview of the unit, it was discovered that a major reason for decreased usage was lack of patient education. Our plan was to assess the patients assigned to our clinical group rather than evaluating the entire unit population. These patients were surveyed to determine their baseline knowledge of incentive spirometry and whether proper education had been provided. In addition, unit nurses were included in the data pool to assess their baseline knowledge and identify potential gaps in patient education related to incentive spirometry use. After completing our assessments, we created simple, step-by-step educational guides, placed them in every room and nursing area, and used them to teach patients directly. We used the teach-back method to confirm they understood the process. By using these guides, we aim to increase IS usage and ensure patients can demonstrate how to use the device correctly by the shift's end, as well as create a lasting resource for future patient education. Our Quality Improvement Project focuses on increasing incentive spirometer use to reduce complications and hospital stays on our unit. 3 key studies strongly support this initiative. The first study found that nearly 40% of patients never used their incentive spirometer post-operatively, and over a quarter used it incorrectly. However, when patients were given a simple 2-minute tutorial and kept the device within arm's reach, usage and confidence significantly improved. This shows that education and accessibility are crucial for compliance. The second study, a randomized controlled trial, looked at nurse-guided IS interventions in cardiac surgery patients. Results showed that patients who received structured IS education and monitoring from nurses had better adherence and significantly fewer pulmonary complications like pneumonia and atelectasis. This highlights the power of nurse-led care in improving patient outcomes. Lastly, a third study examined preoperative IS use combined with deep breathing exercises. Patients who began these interventions before surgery had higher oxygen levels, fewer complications, and shorter stays in both ICU and overall hospital stay. This supports early patient engagement for improved recovery. Together, these studies show that accessible, early, and nurse-led IS education is an effective, low-cost intervention that improves outcomes and reduces hospital length of stay, directly supporting our QI goals. Our Quality Improvement Project used a pre-post intervention design with a quantitative approach. We collected numerical data to evaluate changes in knowledge and adherence to incentive spirometer use before and after educational intervention. To begin, we surveyed 8 nurses and 27 patients across 4 days to assess their baseline understanding of the incentive spirometer. The nurse survey included 6 questions covering key points like the device's purpose and recommended usage frequency, helping us shape our patient-focused interventions. Patients received not only verbal instruction but also educational handouts and a step-by-step visual aid designed to reinforce correct use of the device. Feedback on these materials was overwhelmingly positive from patients as well as staff. These graphs highlight key knowledge gaps in both nurses and patients regarding incentive spirometer use. Only 25% of nurses knew its purpose, and just 1 out of 6 patients with active orders showed adequate understanding and compliance, emphasizing the need for focused education. Follow-up surveys were conducted to assess improvements in knowledge and understanding among patients with an active incentive spirometer order. 100% of them were able to demonstrate proper use of the incentive spirometer through the teach-back method. After assessing our 27 patients, we found a significant gap in both incentive spirometer orders and patient education. Only 6 patients had active IS orders, despite many being post-op or immobile. Of those 6, just 1 had received nurse-led education, while the other 5 were taught by our nursing student team. Only 66% had the device in their room, and 2/3 showed only a fair understanding of its use. Barriers to learning included lack of motivation and limited prior teaching. Still, after our intervention, every patient could correctly demonstrate and teach back how to use the device. Via our data collection, an unexpected finding emerged. The issue wasn't just lack of education, it was lack of orders. After realizing our data pool would be too small by only using patients assigned to our clinical group, we expanded our focus to include all patients on the unit. Even with this broader approach, we found that many patients did not have incentive spirometer orders in place. This limited the number of participants eligible for our data collection and highlighted a deeper issue with the inconsistent IS usage on the unit. On day 3, only 2 of 18 patients on the entire unit had an IS order. By day 4, that dropped to just 1 out of 14. Many of these patients met clear criteria for IS use. Our findings suggest a systemic gap in ordering practices that calls for further investigation and targeted interventions. This QI project not only highlighted gaps in incentive spirometer use on our unit, but also demonstrated how structured education can directly improve patient outcomes. By identifying system-wide issues like inconsistent provider orders and lack of nurse-led teaching, we created change that can promote better respiratory care and reduce post-op complications. The QI process empowers nurses, including students, to be advocates for safer, more effective care. As future RNs, understanding how to assess problems, implement interventions, and evaluate outcomes will be essential to driving evidence-based practice and continuous improvement within any healthcare setting. And now, we'd like to show you a classic episode of The Golden Nurses, where the crew tackles the world of incentive spirometry, Golden style.
Thank you for being a friend. Travel down the road and back again. Your heart is true. You're a pal and a confidant. And if you threw a party, invited everyone you knew, you would see the biggest gift would be from me, and the card attached would say, thank you for being a friend.
Well, hello there, Miss Nyland. You look radiant, just like a Georgia sunset. How are you feeling, sugar?
I'm just a little tired, kind of charging bad.
Well, let me just take a look at your chart. No order for an incentive spirometer. Well, that's fine. You're breathing, so I guess you're good.
What ometer?
Oh, it's just some silly little thing that makes you puff and blow. It's practically a party favor.
A party favor? What are you gonna do next? Hand her a kazoo and hope for the best? Somebody say kazoo!
Oh, excuse me. She's still breathing, ain't she?
For now, she's about one cough away from becoming a Macy's Thanksgiving Day balloon.
Blanche, you didn't check if she had an order for a spirometer?
Oh, Dorothy, it's just a plastic little thing. She's fine.
Fine. You know what else is plastic? The hospital bill when she gets pneumonia.
Dorothy, I came as soon as I could. Is she gonna make it?
Stan, she's not dying.
Oh, thank God. Wait, can I still put tragic hospital visit in my memoir?
Picture this. Sicily, 19-20-22. My cousin, Giuseppe, had a lung infection. You know what happened?
You got better?
No. He ignored the signs, didn't use his incentive spirometer, and ended up in the coffin.
Oh dear.
I mean, he was 94, but still, don't be like Giuseppe.
Let me show you how to use this. First, sit up nice and straight. Hold it upright. Now exhale fully. Then put the mouthpiece in your mouth and take a slow, deep breath in, like you're sipping a milkshake through a straw. That's right. Now hold that breath for a few seconds before exhaling, and we'll aim for 10 breaths an hour when you're awake.
I do that in my sleep.
Stan, the only thing you can do in your sleep is snore and regret your life choices. But honey, we're just here to help you breathe easy. Yeah, but don't breathe too easy. Insurance might charge you extra.
I think that's not even better. That's one take.
Okay, next one.
Thank you all for attending our presentation. As nurses, it is our responsibility to advocate for our patients, not just in the care we provide, but in speaking up for the orders that exist, questioning those that don't serve our patients, and pushing for the ones that could make a difference. Advocacy starts with us.